see some friends and address you the issue of type 1 diabetes. It actually has been all my life, because when I started after my qualification in Rome, I was the first JDRF fellow in Europe. So I'm grateful to the Juvenile Diabetes Research Foundation, because according to what the JDRF told me at the beginning was, I hope that you remain in diabetes, because this is the aim of JDRF, to get talented people, probably I was not talented at the time, but talented people to remain in diabetes. And this is what they did, and I did all my career in diabetes, and then I served for the JDRF on the scientific committee and so on. So I think I'm very grateful to that, because all my life has been linked to that initial start of my career. Now, I think that I'd like to bring you back to 24 years ago, when on the wave of the incredible results of Cyclosporine A in type 1 diabetes of recent onset, there were papers in the New England, papers in the Lancet, and there was a lot of expectation out of those preliminary data. And therefore, in Rome, we had this the first international symposium on type 1 diabetes immunotherapy. And so there we discussed what we should do, how we should progress, and everybody was really excited to say, well, we found a way to cure type 1 diabetes. But indeed, that was not the case. But we can revisit all the data that were produced at that time and learn from what we obtained of those days. In total, just to bring you back to what's happened, 692 patients were treated with Cyclosporine A. That was a very, at the time, was a very interesting new drug that actually has changed the history of transplantation, by the way. I think that it's been probably one of the most, if not the most significant new drug introduced in the market in the 90s. A typical immunosuppressant agent that was used at certain doses, and that was one of the problems that we faced at the time. And the real reason why it was stopped was because there was the expectation that you can cure diabetes, off insulin, remain off insulin forever. And second was that because of known kidney damage in type 1 diabetes, most thought that using a drug that may have some toxic effect on the kidney could have somehow speed up nephropathy in type 1 diabetes. That were the two reasons, not the expected full remission forever and potential adverse effect at kidney level. That's why then we thought, okay, we move somewhere else, but the lesson we learned was very interesting. One reason why it was suspended was the limited duration of remission, because we thought the remission could last 1, 2, 3 years. And then we found that that was not the case and was dependent on the dose. And these are some of the data, in particular on the right-hand side, you can see the effect on C-peptide that is now used as a marker to establish an effect of a drug in type 1 diabetes. What we're looking today is a drug that can maintain, preserve, or even potentially increase C-peptide secretion. And I think that this is an important message to give, that C-peptide is the best available marker today to see an effect of any drug in type 1 diabetes of recent onset. But we have to remember that type 1 diabetes today is diagnosed earlier in the natural history of beta cell destruction. There is awareness of the relevance of C-peptide, and of course, all data are collected based on C-peptide, primary or secondary endpoint, depending on what test you use to check for C-peptide. Then the renal effects of CyA in patients with type 1 diabetes. Now, of course, these studies were carried out in the late 80s, early 90s. Now, patients that were treated at the time with Cyclosporine A were followed for 10, 15, 20 years. And of course, the investigators that were involved in those studies were able to check what's happened to the patients that were treated 15 years ago with cyclosporine. And there was evidence of no adverse effect at kidney level. And indeed, the great advantage was that when we look at the dose that was used at the time, and in particular for a short period of time, about 7.5 kilogram with levels in the blood around 150 nanogram, there was no adverse effect at all and no problems with the kidney function. Just to say what happened about cyclosporine today.
if you take a textbook on medicine, you will find, or a textbook of pharmacology, you will find that cyclosporine A is used in a number of autoimmune diseases as the gold standard therapy. And as you can see here, for psoriasis to rheumatoid arthritis, this drug is used at the dose around 3.5, 5 or 7.5 for certain period. So a dose that was well below what was initially tested in type 1 diabetes, that reached even 10 milligram, that is half a dose of what is used in transplantation. In transplantation, cyclosporine is used at 20 kilogram body weight. In autoimmunity, at a very low dose of 5 milligrams.